Good morning, everybody. Good morning, everybody. Aha. Maybe this one. Good morning, everybody. No, that doesn't work either. Good morning, everybody. How's it going now? If I say good morning, everybody 4 or 5 more times. So thank you all for coming to the Florence Edelson Memorial Lecture. This was established in 2002 by Helene and George Edelson to honor the life and memory of George's mother, Florence. And her husband was staff physician here at St. Vincent Hospital. And the perpetual lectureship brings the highest quality programs, especially today, of educational interest to caregivers, and with an emphasis on nutritional and integrated medicine approaches. And the Providence St. Vincent Foundation particularly appreciates the support from the Edelson family. And we have the privilege of having Helen Edelson here today to listen to this lecture. So I don't know if you'd like to stand at all, Helene, and with thank you for your supporting this. And we have, speaking for us today is Helen Delichatsios. Dr. Delichatsios is a clinician educator at Massachusetts General Hospital. She has an active primary care practice as well as being involved in the education of postgraduate and medical students. Her research interests and publications concern effective nutrition and obesity counseling methods in the primary care office, and she runs shared medical appointments with patients with metabolic disorders. Emphasizing self-management of their problems through teaching and cooking. She is a graduate of Cornell University Medical College, residency at Cornell New York Hospital in Manhattan, Master's in Science and Epidemiology from Harvard. And she's also active in her town's wellness committee. You are in a lot of committees, Dr. Delichatsios. You must be a great networker. Her goal there is to improve nutrition and health in schools. So thank you very much for coming.
Thank you for the kind introduction. I've been described as a wanderer. I'm a fidgeter, so that's why I can't sit still, so I'll be walking around a little bit. I have no disclosures, except I like food. I like thinking about it, looking at it, planning it, eating it, teaching about it, and sharing it with others who also like food and also who don't, and maybe I can encourage them to like it. To start, let's look at a definition of nutrition. So a simple definition is the process of eating the right kind of food so you can grow properly and be healthy. Now, simple does not always mean easy, and that's a common theme that I'm going to get back to. Let's take a look at some revolutions in food technology that really changed how we eat. A big one 2 billion years ago was the invention of stone tools and fire, which greatly diversified the food supply and gave more options to our predecessors. The agricultural revolution domesticated staple grains and vastly increased the number of calories available to humans and increased the population on the earth. More recently, the Industrial Revolution made sugar and flour, mass production, packaged foods, a ton of calories at our fingertips. In the past, time used to be a limiting factor in the amount of calories that we could eat. However, now, with calories at our fingertips, you could satiate your desires pretty much instantly. And today, we have ultra-processed foods, and one may wonder if they're even foods. And we'll come back to that. So this, as an example, is, I don't mean to single it out, but this is available on the web. It's called strawberry fruit gushers, and there's no even strawberries on the list here. There's a little bit of pears, a little bit of grape, and the only reason pears is first is because the next 5 ingredients are sugar, sweeteners, and ingredients go from the reason they separate them is that so they don't become first, so you think you're getting a fruit first. Anyway, we'll come back to that too. What I'd like to do today is just bring us back to the basics, bring us back to food and how we can, both for ourselves and our patients, appreciate it and eat it and be healthy. I've listed here the objectives that I'm going to cover. I'm going to share with you some of the challenges that I face in my primary care setting and other primary care settings. And these challenges are really applicable to all medical disciplines. Just a show of hands, how many people are generalists in the office, primary care, internal medicine, and then I presume the rest are specialists of some sort. So what I'm going to talk about, if I say primary care office, that's because where I practice, but it's applicable elsewhere. And then we're going to talk about group visits, a special type called shared medical appointments, and more on that. And finally, the importance of self-care and how not only nutrition, but how we take care of ourselves can impact our patients. Here's my 3 hats. As I'm going through the talk, I'd like you to think about the issues I talk about with the clinician hat. Try to put yourselves in the patient's perspective and see what they're feeling from the words that we're using, and then think about what I'm talking about as how we take care of ourselves as people. Now, in medicine, we learn about many conditions. However, something that we all do is eat. So everything that we talk about today is applicable to you, unlike possibly some other lectures that we go to. Okay. Hippocrates. Way back when, he said, the function of protecting and developing health must rank even above that of restoring it when it is impaired. Think about your last patients that you saw either in the clinic or in the hospital. Chances are they came, at least in the hospital, for some acute issue that warranted their hospitalization. And obviously, we're going to take care of that. But if you step back and figure out how they got there in the first place, chances are that poor nutrition or some poor self-health habit led them to that condition. And this is just a reminder that the urgent shouldn't crowd out the important, that we should step back and think about how they can prevent a further event of whatever they had in the hospital. So in terms of healthy lifestyles, this is a study that looked at how many people had these particular life habits: non-smoking, healthy weight, eating fruits and vegetables, and physical activity. And these are the numbers here. If you had to guess how many people in this series at least had all of the 4 habits, how many do you think? 3%. All right, you've seen this slide. 3%. And that's true. That means that we have a lot of work to do. So let's take a look at counseling. Do people recognize this figure? This is the diabetes prevention program that's now almost 15 years old. But what it showed is that, yes, if you take people with impaired glucose tolerance and you put them on an intensive diet, exercise, and weight loss program, you can reduce their risk of incident diabetes by 58%, more than with a medication. So it can work. Is it recommended? Yes. Numerous societies have recommended behavioral counseling for nutrition to promote a healthy diet. Here are some of the recommendations that we're supposed to do in working with a team. Now here's the question. It works and it's recommended. Does it happen? Unfortunately, not as much as we'd like. Numerous series have shown that about 1/3 of the time some nutrition counseling is going on in office visits, even in visits with high blood pressure, cholesterol as the diagnoses. And I'm embarrassed to say, I'm going to share a story with you. A few weeks ago, I had a pre-medical student wanting to shadow me in the office because he was interested in nutrition, and that's how he connected with me. And at the end of our busy morning, one of his comments to me was, "Gee, Dr. Delichatsios, you didn't talk about nutrition with any one of your patients today." And I thought, oh my gosh, it's so easy to, what I was saying earlier, that their lists crowd out what we really should be talking about. This was a little disheartening. This was a recent study that looked at weight counseling in obesity and rates of obesity between the decades of the mid-90s to the late 2000s. Although the rates of obesity have gone up, the rates of counseling, if anything, have gone down. And this is especially important because it's been shown that if doctors talk to their patients about weight and trying to lose weight, the patients are more likely to try to attempt weight loss. There's barriers. I'd like to see what barriers you might face in your practice when you try to talk to patients about nutrition. I'll just shout them out. Time. Epic, okay. I like that, I like that. We just went to Epic less than a year ago, so I'm with you there.
Feeling demoralized that it just doesn't work.
Demoralized that it doesn't work. I'm going to label that futility, yep.
Feeling like if I have not achieved perfection, who am I to impart?
Okay, yep. So feeling like an imposter if you're not.
Pretty close to perfection.
All right. Those are some of the main ones. So time leads the list for most of us. And then the approach, maybe the epic, fear of offending patients is what some people say. I don't want to, weight is such a big taboo. The futility, and then lack of skills and training. And I liked yours, the imposter one. In terms of the futility, I'd like to point out this study. Now this study looked at, we're going to call this group middle-aged people. And over the course of the next 6 years, the group of people that were in this age group that didn't already have all 4 of these. Now if you notice, the BMI criteria is less stringent. It should be 29.9. It's in the normal and overweight category, not in the previous study where it was normal weight. If by the end of the cohort time they adopted all these healthy habits, which are not too hard to adopt, they had a reduction in mortality and cardiovascular events. And my point with this study is it's not too late. It can make a difference.
What were the absolute numbers?
I have the study in my bag. I can show them to you. I don't know them off the top of my head. That's an excellent question. Now I'd like you to put on the patient's hat and think when you're the patient in the room and the doctor tells you to change your habits, what are some barriers that the patients might face?
Cost, time.
Mm-hmm. Motivation, time, cost. Okay. Knowledge, yep. Okay, so many of the same things. The cost, the time are top there, the inadequate training. Patients sometimes say, why bother? Was it going to make a difference? And then finally, think about yourself, and you get the theme here, which I'm getting at. What are some, when you're trying to make changes in your own health habits, what are some barriers that you might personally face?
Carbohydrates.
Carbohydrates, okay. The allure of discipline, okay.
Eating out.
Yep. So being organized, the time, of course. For, I like to do this one, the offending one, fear of offending family. I like to cook fish, but neither my husband or my daughters love it when I make fish, so I have to think about that. So what I'd like to do today, this morning, is think of some tools that we can all use, both as clinicians and that the patients can take home and that we can take home. So, starting as clinicians. Number one thing that has been shown to work is just put, if the patient has the obesity diagnosis, put obesity on the problem list. Now that sounds kind of simple, and it is simple. In this series, that's the study reported here, they looked at who had heights and weights measured, and not everyone had heights and weights measured, so you can't even calculate BMI. But among those that did, less than half that fit the obesity category had obesity on the problem list. And again, the reason this is important, because if obesity is on the problem list, you're more likely to address it with the patient. Just like we have high blood pressure, diabetes, coronary disease, gout, we've got our great electronic record now that has some benefits. And if we put that there, we can tackle it as a separate line item. And this leads into number 2, putting it on the list and then acknowledging it. Because sometimes patients are not on the same wavelength as you are. If the people that patients hang around with are all their size or bigger, they might not realize that, average does not equal normal. And you actually have to verbalize in this study, the great study here, until the physician told them your weight puts you in the obese category, the patients didn't consider themselves obese, for example. And this is very important. A whole other topic about the language and the words that we use, those are crucially important. I don't want to minimize that, and that's something that we should watch very carefully, how we use our language. You don't want to say, for example, you are obese. It's better to say your weight puts you in the obese category. Little things like that can make a big difference in how patients perceive what you're telling them. And then there's not going to be a movement to make a change unless people realize that there's a problem. So acknowledging it. Put it on the list, acknowledge it. Here's a simple tool as well. When I started practice, I used to write paper prescriptions. I don't know if anyone still has prescription pads. I have a whole stack now since we're on the electronic medical record. So sometimes I just take my little paper prescription and just write, take a fruit to work, or some simple tip that the patient and I can negotiate, and I say, stick it on your refrigerator so you remember me when you open your fridge. And then if you do have more than 30 or 40 seconds to talk with the patient about nutrition, in most of these studies that's the amount of time that we have that people talk about nutrition, trying to elicit some goals, do some motivational interview and come up with some goals together. And how much time do you have for a follow-up visit in your outpatient clinical practice? 20. Okay, 15 to 20 minutes. It's hard to do nutrition counseling along with everything else all in that 20-minute visit. And you don't have to do it all at once. And there was a great study that looked at texting as an intervention. Now there's so many apps out there and technology that a lot is possible to be done remotely. And one of the problems is because technology is moving so fast, all these interventions can't be studied. In this particular study, they looked at men mostly who had a cardiovascular event, and they looked at secondary prevention. And they texted them 4 times a week for 6 months, general text. It didn't require responses, but reminders. To add interest to your meal, try a new fruit, or have you taken your walk? And what they found was that at the end of 6 months, there was improvements in weight and LDL and blood pressure. Again, short-term study, but intriguing. You can think about if something like that would work in your practice. I've actually adopted this with my husband, and I send him periodic texts to remind him to eat well. So now let's take a look at the patient's perspective. We said that time tops the list, not only for doctors, but for patients as well. And when patients say that they don't have time, I remind them of this quote. I don't know who wrote it. Maybe someone can tell me, but I found it somewhere. If you don't have time to be sick, you must take time to stay well. It's again, people who come to see me often are sick, so, or not always, but if it's not their annual, that they're there for a reason. And this is actually a quote. There it is right there. If you don't have time to be sick. I have this in my exam room. I have this wall with my pictures and my tips that people can stare at while they're waiting for me because I'm running late. And I prime them so that they ask me some questions about it. And then again, if I only have a few minutes or 1 minute to talk about some benefit they can improve in their habits, cutting out sugar-sweetened beverages is a great low-hanging fruit, to make a pun, that can make a huge difference in someone's weight if they do drink. And again, not just sodas, but 100% fruit juices if they drink a lot, or caffeinated beverages with a lot of cream and sugar. Those are great, easy targets to replace. Another thing I like to do with patients is look at food labels. This is actually the new nutrition label that's coming out. It's going to be phased in over the next few years. This is what the current one looks like. But regardless, reviewing food labels with patients, if you have access to internet, when you talk to patients, you can pull up, for example, their restaurants that they frequent or their packages that they eat, and just review it together and remind them that a serving size is not the size of the container, for example, usually. And then finally, we can't do it all, not all at once. Schedule follow-up, and then consider group visits. And I meant to ask Miles this morning, and I don't know much about medicine in Portland, but are people doing group visits? Not much. 1, 2. They are at Kaiser. Oh, at Kaiser, okay. So group visits or shared medical appointments tackle many issues. This is a nice graphic that looks at how we can practice medicine. Now, traditionally, it's one provider to one patient. This is an article looking at industries, so that's why they say client, at a time. And in the hospital, usually the patient has multiple doctors on their team and other team members. But we can consider whether it might be more valuable if we have one provider to many patients. And this can get to the issue of time, both for the doctors and the patient. Access, I'm not sure how easily doctors have access for their patients. And it's a great way to manage chronic health conditions. And they are gaining ground across the country. Now, I'm going to talk about shared medical appointments. Has anyone heard that particular term? This is a particular term that in the setting of a group visit, it's actually a medical visit where we talk medicine, we check blood pressure, limited physical exams, and anything that I can do one-on-one that is not HIPAA inappropriate, I can do in front of the witnessed environment. So adjusting medications, obviously counseling, flu shots during season of flu shots, blood work, and preventive services as needed. People see their usual provider, myself in this instance, and the usual billing and co-payment applies. Now, billing always comes up when I mention these visits. Again, I'm not sure how practice is different here. However, I usually bill for a low-level, level 3 established visit. And now I'm going to just take you through how I run the shared medical appointments. And this is a great avenue to explore. And it's something that I decided to do about 6 years ago, just to do something different. And I didn't have to go beyond what I already had in my office. This is a picture of my office conference room. It comfortably seats about 15 people. You'll see a whiteboard on one end and a projector. You'll see the projected on the other end. For the sessions that I do, I recruited patients with metabolic syndrome. So anyone with high blood pressure, cholesterol, diabetes, overweight, cardiovascular disease. And I probably have about 80% of my panel who fits that diagnosis, one of those diagnoses, so pretty much anyone is welcome. I recruit them during a regular office visit and say, for your follow-up, come see me in a shared appointment. The staffing is my usual secretarial and nursing assistant staff, and then sometimes I write session-specific if I have extra staff with me, for example, a medical student or a visiting chef or a visiting dietitian. They go through their usual check-in process, which includes vital signs. And then as they come in, I have them sit here and they talk amongst each other. I do a general preview of the confidentiality of the session and basically what I told you. And then we start delving into patient concerns. I ask them to write down what concerns they might have, and then we just discuss them as a group. So I take the lead from the patient. I've done a lot of preparation to see what might be needed for that particular patient, but I let the patients lead the discussion. And then we do a mid-session stretch. It's not the focus of my discussion today, but physical activity and exercise is also a key component of healthy living. So I incorporate that. So this is a picture of us pulling up a video from the internet. And it just shows you how, again, you don't need a yoga room or a huge office space, but even a conference room, you can get in some physical activity to make the point of becoming more active. The most fun part of the shared appointments, which I'll come to, is a cooking demonstration. And then finally, I ask for some feedback for future sessions. So because poor nutrition and physical inactivity and being overweight or obese can affect many organ systems, the range of the discussions that we have in the visits can be very broad. So we cover not only the metabolic conditions, but also arthritis or obstructive sleep apnea. A big focus, people want to work on weight loss strategies, so I'll share with you some of the tips that I give them. So this is an example of the whiteboard with the blue on the left, what people brought up for questions, and then the red, we go through various tips. So it's sort of like a classroom, and I do encourage the patients to inform each other. It's so powerful when someone who has diabetes tells someone else who has diabetes what might work or might not work, rather than me trying to convey that same information. These are just some examples of topics that, in addition to the medical aspect, some of the nutrition topics that we cover. Because I'm interested in nutrition, and I feel that nutrition can be very powerful in changing their health, I sneak in the sodium, the healthier carbohydrates, and the other nutrition-related topics. At the bottom, I write other approaches, and I'll give you an example here. So in addition to the actual knowledge, I try to focus on tips. So if you want to just estimate how many calories are on that plate, there's a burger, some corn, some pasta, and lots of greens, approximately. So it's hard to tell size because it's on a screen, but I did the math. It's about 400. These aren't very big things. Okay, so now keep that in mind. This was about maybe 400. The next one. This has a little bit more. It has the bun. It has more pasta, an extra hot dog. Yep, where's the dietitian, or how dietitians in the room? Yeah, you can. Yeah, you can correct me. It's closer to 850. And one of the reasons you can get so much more food on it, and again, this is cheating because you didn't see them side by side until now, is the plate size. Now, we eat a lot with our eyes, so when you see this plate in isolation, you might say, oh, this is a good portion, I'm happy to eat this, this is going to make me full. And this is true. When you have a bigger plate, more food ends up on it, and the more food that ends up on your plate, the more you eat. So these are the sort of tips that not only I use with my patients, but I've tried to use when I have my dinner parties. This was barbecue at my house. I serve people on smaller plates to try to encourage my guests to eat healthier as well. Okay. Many people have shown that, yeah, my husband did work once on caloric restriction, so that was a fun dinner party. So this, the using smaller plates is not new, and it comes from the work of Brian Wansink, who also has great other tips. And again, these are the sort of behavioral tips that people can take home and do right away. I love, if you're thinking of having a snack, eat a fruit first, then you can have your snack. Transfer food, don't eat from a package. And the environment is huge. So out of sight, out of mind. My office coworkers know this about me. I have chocolate in my office because I like chocolate. However, in order to get it, I have to reach over my roommate's head into the overhead bin, into a closed bin. So there's 4 steps, and I have to bother her. So I'm less likely to eat it rather than having my fruit on my desk. That's my constant reminder, okay, I'll have that first. And again, sometimes I bring patients to my room and show them that. I also love the work of Michael Pollan. He's written many books, which I'm sure you guys are aware. And one of my favorite ones is this very short one called Food Rules. Again, simple. Eat food. And how do you know it's food? Well, it's not if it arrived through the window of your car. If it came from a plant, eat it. If it was made in a plant, don't. And there's 60 or so of these rules, and each of them are very short aphorisms like that. And probably the most famous one is, if your grandmother doesn't recognize it as food, it's probably not food, where the first gusher came out. And here's another very simple one, is cook. Now, the rates of obesity are correlated with the rates of home cooking. And as the home cooking has declined, the rates of obesity have gone up. And around the world, in nations that have more home cooking, there's less obesity. Now, there's other factors at play, but I think it's something to keep in mind. There have been multiple studies, association studies, that show that people who cook at home do have more vegetable consumption and healthier diets. So how best to teach this to our patients than to just do it? Now, there was at least one person, I don't know if he's in the audience, who went to the Healthy Kitchens conference? At least once? Okay. There was at least one other person. So you'll recognize some of the concepts that I'm saying here, because a lot of them I got from there. But the best way to teach someone about it is to do it together and to have them do it and to eat it and to share it. So when I do my group sessions, I devote the last 25 or so minutes to the recipe. So this is a very simple recipe. This is a traditional Greek salad. It doesn't have lettuce. It has all the ingredients listed here, and you don't need any stove. I don't have running water in my conference room. I have a kitchen, a small kitchen next door, which I prepare all my produce. And as long as the patients feel comfortable, I have them wash their hands. I put cutting boards and knives in their hands and have them participate. It's so fun to do it together. And at the end, we have some whole wheat bread and we share it together and we have community and enjoy this meal. Here's another example of a simple meal that I demonstrate for patients, and this is a great template. In this particular instance, it's a brown rice salad, but any grain really can do. Just in order of logistics, I usually prepare the grains at home the night before if they take a while to cook, because I don't trust myself that they're going to be to my perfection the day of. But in terms of chopping up the vegetables and putting together a vinaigrette, that's simple enough to do as a group and enjoy as a group. Smoothie day is always fun. How many people in this room have never tried a smoothie? Right, I didn't want to ask it the other way around. So most of us as healthcare professionals maybe either eat them on a regular basis or at least know about them. Many patients have not, and that's something that sometimes we forget. There's this divide between what we might think is usual or not. One thing that I'd been very reluctant to try until one of my colleagues recommended it was a green smoothie. And when I do this demo, I do the before the green and then I add the green and have people taste it. And at least getting people to taste it, to go outside of their comfort zone, that's a plus. I still have yet to convince my husband to taste a green smoothie. And it's fun. Sometimes I'm alone. Sometimes I have assistants. This is a medical student. This was a wheat berry salad that we did more recently. Another example of usually if people ask me if they can come to one of my group sessions, I say sure, and they become my next assistant. This is another medical student and a dietitian. We did a mango, bean, lettuce wrap. And again, not too complicated. So we're up against a lot of battles. This is the picture of the outside my office. And if you can't read it, it says, "Keep your kitchen clean, dine out." So that's kind of what we're up against when we're trying to convince people to eat in. However, there is a counter to that. This was an article just from a few weeks ago in the New York Times about dining in and homemade chili gains ground on chilies, so that was heartening. And speaking of chili, just peeking at time, it is another staple that we do in my house, and another tactic that I recommend not only for people and patients, this is a tip that I learned from the Healthy Kitchens conference, is when you make a batch of chili, make extra so you can freeze it. So however many people you're serving, if you're able to freeze another 4 or 5 servings, those are lunches in the coming weeks. And if you keep your freezer organized, if you do the big pot of something every week, you'll have varying lunches. And this is great tips to show your patients and yourselves. There's a whole other topic to talk about what you can freeze and how to organize your freezer. But just briefly, grains you can make and freeze in single serve portions, beans, leftovers are great, and I definitely encourage people to use their freezer. So back to the shared appointments. About a year ago, my colleagues and I, we published the report of our series, and I do have reprints and an editorial if people are interested. I brought some copies. We had 25 sessions, 70 plus unique patients. They liked it, they came back. There were anywhere from 6 to 12 participants per session. It's always hard to, you can't always guarantee who's going to show and not show. And for the most part, people liked it. And I think, what about the physician? This is me in this case. I did hear a little comparison of what my traditional session is like versus a shared medical appointment. And in terms of preparation, I spend more time preparing for the shared appointment since I can't look at individual charts during the session. The sessions I run are about 90 minutes, and I spend about the same time afterwards charting. And in terms of RVUs, it's comparable. However, a big difference is usually I'm pretty burnt by the end of a regular session, whereas after a shared appointment, with all the excitement of eating together and talking and thinking about the next one, I'm energized. And we were talking earlier how this is so crucial because in this age, physician burnout is such a problem, and we need to figure out how to look beyond the traditional model and how we can make things better. And this is true not only for physicians in practice, but physicians in training as well.
Could you explain 3.5 hours for a traditional appointment?
So this one right here? I usually, what did I write here? 8 patients. So in those 3.5 hours, I would see 8 patients, a combination of physicals and follow-up visits, and it would take me this much time to chart. So the total time here I estimated 4.75 hours. And the shared appointment, I would see 10 patients, but they were easier to bill for, to code. So this is just a gross estimate. It's like my own practice. I wanted to make sure that I developed something that was sustainable and financially neutral for me. So finally, probably most importantly, I want to talk about us, clinicians, and how the importance of self-health not only is important for our own medical care and the diseases that we get as we get older, but also how it impacts our patient care. Dr. Frank has done a lot of work in this area and has published numerous studies that not only among physicians in practice, but trainees and medical students as well, the healthcare professionals' own practices impact what they tell their patients. So for nutrition, for alcohol consumption, for exercise, for cancer screening, for smoking, that someone who does the healthier habits is more likely to counsel their patients on those habits. This was an article by Dr. Bleich and colleagues looking at the body mass index of some primary care physicians. And what she found in this cohort was that physicians with normal body mass index as compared to those who were overweight or obese physicians were more likely to engage patients and had greater confidence in their ability to provide diet and exercise counseling. So this is a great opportunity. If we're able to improve the health of our healthcare community, it can impact a lot of people. The Institute of Medicine came up with some recommendations recommending that healthcare professionals, we should be role models, and that food served at medical meetings sometimes does not adhere to guidelines. I was very happy to see the breakfast offerings here. I was a little nervous. This is a conference for real that I went to a few years ago. It was a cardiovascular conference, and I won't say where. Of course, I was shocked, and I had to take a picture. I like to take pictures. And I asked some of the attendees, saying, what do you think of these offerings? And half of them said, yeah, this is kind of inappropriate, this is embarrassing. But the other half said, well, we try to eat healthy other times, why not indulge sometimes? So I was shocked. But then I realized that they're not alone. I don't know what the culture is, both in your practices or in the hospital or in your community. My colleagues know that I'm interested in nutrition. And within the 10 of us, we have a weekly lunch that we decided as a group to do. And there was this huge debate, or not a debate, I brought up the point, like, do we really need dessert? We have so much access to sugary. Let's just have a meal. And there was silence. My colleagues said, some of them sheepishly said, I like my weekly cookie or something. And I could not get my practice to commit. Thankfully, our medical director at the time came up with a compromise and said we're going to do dessert every other week. It's not an issue now due to budget cuts. We have to bring our own lunch, so that's gone. And then another example was quite shocking. We were talking about Mediterranean diet earlier. Here, I'm going to change the picture. I don't want to look at that. We had a conference, Grand Rounds on Mediterranean diet, and one of the doctors in the audience at the end of the conference raised their hand and said, is it worth the sacrifice to not eat what I'm eating now to switch to a Mediterranean diet? And I was very appalled because I was thinking, oh my gosh, what are you talking about? A sacrifice? Mediterranean diet is so delicious and healthy and appealing. So there's a big culture switch that needs to happen. Not everyone is aware that healthy food does not equal not tasty. This just brings me back to we can do better at medical meetings like the offerings here. This was a recent nutrition education conference I went to. You have to imagine all this is in one line. It just didn't all fit in the slide. But healthy offerings can be both visually appealing and not too costly and tasty. And which leads me back to the conference. Healthykitchens.org is the website. It's a collaboration between the CIA, the Culinary Institute of America in Napa Valley, California. Apparently it's the original CIA, and the Harvard School of Public Health. And chefs and physicians inform each other on how to eat healthy, both how to the chefs get teaching on what is a healthy diet, and the physicians and the health professionals get input from chefs as how to prepare them. So it's a great conference. So, take-home points. Sometimes at the end of a talk like this, I actually pull out my food and do a food demo and pass it around to taste. However, the logistics of traveling cross-country into a place I've never been before, we're beyond that. So instead of take-home foods, we've got some take-home points. And the main thing is, I can't overemphasize the importance of taking care of ourselves, because if we don't do that, we really can't take care of our patients. And not only that, if we have better habits, like I showed you, there's been multiple reports that we pass those on to our patients, and then they can take care of themselves and their families. So think about today, you, what you're going to eat next at snack or lunch or wherever, and the next patient that you're going to see, and what you might tell them a little differently. And I think sometimes as health professionals, we underestimate the impact that we have. And to reiterate this quote, 80% of US adults see their doctor annually. So we're in contact with pretty much the whole population. So I'm going to show this quick video, and I'll explain it afterwards.
Hello, and welcome to this episode of Let's Get Cooking with Carolyn. Today, I'm going to show you how to make a traditional Greek salad. It doesn't have any lettuce, and a friend showed me how to make this, but I've added a different garnish at the end, you'll see. What you need are 2 tomatoes, and you need 2 cucumbers, and Kalamata olives, salt, pepper, oregano, and some parsley, which is the extra garnish, some feta cheese, and some olive oil. I've already put everything into the bowl. These are the extra cucumbers and tomatoes, and you would need maybe a handful or so of the Kalamata olives, and a little bit of feta cheese, which I already have in there, about a half a teaspoon of salt, and a half a teaspoon of pepper, and which makes extra flavor, is about a tablespoon of oregano. And for garnish, I add some parsley, flavor, and about 3 tablespoons of olive oil. And then you want to mix it up, and you have yourself a very healthy Greek salad, which you can also have leftovers for lunch. And enjoy, and thank you for watching, and tune in next time. Thank you very much.
So this was a patient of mine. She came to my session on, hold on, let me get rid of that. She came to she's been to multiple sessions, but she was there at the one with the Greek salad, and she basically took it home and made a YouTube video out of it. It's online, it's legitimate, I can show it. She said I could show it. But that goes to show that people listen to us, and just teaching them something simple like that is so powerful. That's a common one that people say, oh, you know, in the summer I do that, and it's easy. But even some other a little bit more involved recipes, the various soups, people go home and try them. It's so much easier to try a recipe if you either watched it or did it yourself and tasted it, as opposed to reading it in a cookbook or watching it on TV. It's not quite the same. So that's one of the principles of actually doing it yourself that is powerful. So I encourage you to try some of these things. And I wanted to thank you once again for having me. Question?
Just a comment. I want to let the staff know we do have a teaching kitchen in Milwaukee, and they use the program Cooking Matters, which is aligned with all these. It's a wonderful, and we have a medical model of nutrition counseling in outpatient here, but it's just magic to see how the education happens in the teaching kitchen. Exactly like you said, it's pretty amazing because people just don't know how to do it. They don't know what food groups are. They don't know any of that, and it's a wonderful curriculum. And I think it's from the food bank, and they have the courses in the.
Yeah, just to get at that, teaching kitchens are great, like a laboratory where you can bring people in and do things like that. Unfortunately, many offices or facilities aren't equipped with counter space or you know, the kitchen in my office is very small. It's good for 3 people, and there's no heating element. It's just a microwave and a sink. My attempt, what I did in my office there, is to do things despite the limitations. You know, what can I do in a conference room? I don't, you know, I'm not going to, I bring in an immersion blender, for example. I can bring in my rice cooker. I bring in my blender. So there's things that you can do even with limited resources. So thank you.
What happened to the Red Sox?
Yesterday? I don't know. They lost. I was flying. Yeah, here, I think you were next.
Can you elaborate a little bit more about how you approach talking to a patient who's clearly overweight or obese and use the proper terms? Because there also have been articles about people that are overweight or heavy that are offended. And they won't go back to see the doctor if the doctor mentions it. And I know, I mean, I wasn't in primary care, but trying to explain
Yeah.
the additional risks and trying to phase it. I
Yeah.
just say, well, when you're not at your ideal weight, these things can happen, you know, to someone who is clearly 200 pounds overweight.
No,
How do
that's
you say that to keep the patient on your side and not immediately?
right. And it's hard, I guess, as a primary care doctor, where you have a relationship, there's the trust and there's the history. So in some ways it might be easier than someone who's seeing them only episodically or for the first time. There has been various studies on the words that people like, usually focusing on healthy weight, unhealthy weight. Like, those are very non-judgmental, as opposed to morbidly obese. That's not a word that anyone likes. And just like you said, and like I was saying earlier, couching it in a neutral, in a objective form, not you, but at this weight, the risk is increased. And I don't know if you were meaning one-on-one or in a group setting, because in a group setting, obviously, you'll also.
I would say if you're trying to establish a relationship at any point, and there people say, well, you're fat, you know, you're people, I'm fat and I'm proud of it, or it's curvy, or you know, you need to understand this is how I am. I mean, how do you get that person to address have a relationship with you as
And you can, again, over time, because it might not be possible on the first visit, but then also looking at their other metabolic indices, their blood pressure and their lipids, and saying how they can be improved with improving your diet and exercise. I like to tell my patients I don't like to focus on the absolute number, but rather the habits. And again, it's hard. Yep.
I'm wondering if you have a culture in your office among the staff as well as your physician colleagues around like not bringing in huge boxes of donuts like are in our office this morning. Is there? Do you try? Is there any sort of agreement, or do you have junk in your office as well?
I mean, this is the problem not only in the offices and the hospitals and the school system, which I also, it's funny, it's the same battles, whether it's in the middle schools or my office or the hospital. For celebrations, people bring donuts, and just trying to change that culture. So move it to some seasonal fruit. Apples are in season now. But it's really hard. I word attend sometimes, and I tell them that I'm interested in nutrition, and I usually bring in some different fruit every day just to be a role model and lead by example. And then when whoever or my co-attending brings donuts, I'm like, oh. And it's so hard to say. Same thing in my office. Patients often bring treats and snacks and chocolates, and unfortunately they sit out in the main area where all the secretaries sit, most of whom are overweight, and it's challenging. It is a really hard, yeah, it's a culture thing. Yep, question?
How do you talk to patients about having treats in moderation? So for people who are like, I am not giving up something entirely. How do you make a recommendation?
I have a good one for that. So lots of different options. So there's, for example, the don't have it in your house. Like if you like ice cream, that's fine. I'm not telling you never to eat it, just don't have it in your house. So if you get a craving, you actually have to physically, I don't know if you can walk to ice cream here or get in your car and drive somewhere and buy a single serving. So I'm not telling you not to eat it, just don't store it. Or if you do have it in your house, the 5 Ds, I can only remember 4 of them, but distance yourself, like put yourself in a different room, or delay, say I'm going to eat it in half an hour, and maybe you'll forget. Well, or distract, go do something else. Dental, brush your teeth. So little tactics like that, just making it a little harder, because things are so much at our fingertips. One of the, I don't know if it was Michael Pollan or some other person said, the best way to lose weight is to cook it yourself. So if you do want a treat, bake it or make it. Or has anyone ever tried to make ice cream? Yeah, I mean, it's doable. It takes maybe 4 hours. And you come out with, okay, but you come out with a serving size like this big, and if there's like 2 or 3 people involved in the ice cream making. So,
I bought the big version.
okay. But still, making it yourself, you appreciate it more. You're not going to go through a half a gallon in 2 days. So things like that, little tips. And I think the psychology and the tips work not only for patients, but for ourselves too, and how we can just make the healthier option easier. Wansik writes a great book. He calls it Mindlessly Eating Better. So just making it so that we make the healthier choice without thinking about it, because it's so easy as you're walking by whatever cash register. There's always a snack. There's always chocolate there. But just moving it out of there, for example. Sorry.
We always hear that breakfast is the most important meal of the day. Is there any scientific information about that? Is it the content? Is it the timing of the meal? Or is it a marketing strategy by Kellogg's?
That's a good one. Yeah, that is definitely one of the things that's recommended. I can't remember if that was. There's proponents on both sides of that. I'm not up to date on the literature, on the science behind that. I'm personally not a breakfast eater, so I don't practice that. So I don't preach it because I don't practice it. Maybe if within my family, there's 4 of us. Oh, the dietitian's going to respond. 2 of us are breakfast eaters, and 2 of us, my rhythm is I'm not hungry until 3 hours after I wake up. Does that count as breakfast? So let me hear what, there you go, see? See, that's why we all.
Watching your whole diet, so it's not probably an issue. But if somebody doesn't eat for a really long period overnight, they go into a fasting
So there you go. It depends. Yep.
I have it in my mind in this very subjective and difficult area where it's been so hard and physicians have failed for so many years to help people lose weight. I have it in my mind that I see patients that where it really makes a difference is I see patients who suddenly, having nothing to do with anything I have done, have transformed their lives. And that these incremental things are really not very helpful. I have that in my mind.
Okay, I'm gonna get back at that. Yep.
I sometimes see someone who walks into my office and they are fundamentally different.
Yeah.
They're now leading a different life than they were when I knew them before. And it seems to me that that's what I want to try to encourage, although I don't know how to do that very well.
No, that's great, and I've definitely seen that in my practice as well, because I feel like I'm hammering these messages. I feel like a broken record, and then every now and then I see someone who's transformed, like you said, and I usually ask them, like, what was it? What happened? Usually it's either some life event or someone's divorced and they want to date again or something. That was one particular case I had. I think, though, like I was saying, we shouldn't underestimate, even though we think we're beating a broken record and they're not listening. I think at some level they are, and maybe there was a tipping point that made them change, but what you were doing until then, it wasn't for nothing. So I would encourage you to keep, for all of us, to keep incrementally.
I'm just curious about the psychology part. Is there a psychologist involved in some of these emotional eating responses that some people?
Yeah, I mean, obviously, I'm sure everyone's aware there's a lot of stress eating. There's a lot of people. I don't have a personal dietitian or psychologist that I use. I try to share whatever I learn with my patients, and there is a lot of emotional eating that happens, and trying to address the emotional part. Otherwise, you're not going to address the emotional eating part. So yeah, that's huge. Yep.
So I have a number of older patients, and when they sort of go through their diary, I mean, they're eating well, and they still just don't lose weight. And I just look at them and I say, life is just not fair. If I ate as well as you, I would be really thin. So how do you deal with that?
Either they're not reporting everything, which is possible, but assuming they are, sometimes, what I tell them in that case is I say, this is great. Possibly there's some small things to tweak, but if they're overall healthy, it's hard to make extra changes. Make sure they're exercising some if they're not already. And then focus on, if you have the healthy lifestyle and if you're exercising, this, you're doing all you can do for your health, and this is, yeah, I mean, obviously make sure there's no other metabolic things going on. Yep.
I like the steps, and I like physicians suggesting, but you only have, like you said, what?
30 seconds, yeah.
Registered dietitians, referring to them.
Yep.
So a registered dietitian would sit down for an hour
Mm-hmm.
and have a lot of time, and then they can follow up. Especially those patients that are inquiring and want more information. The ones that really don't want to listen to you if they're not ready.
Yes, I apologize. I should have mentioned that in the team. Registered dietitians and other health exercise physiologists, not that I have any, but they always talk about exercise physiologists. But registered dietitians, I do have ready access, and I generally refer to. For me, it's like anything, everything. As long as people are thinking about their health, thinking about their nutrition, they're more likely to do something. Because people, when they leave the office, they go about their lives and they don't think about food like I do all the time. Yep.
I would suggest keep it simple and give them one take-home message like, oh, you drink sugared beverages. Well, let's identify what those are, and maybe that's our goal.
Yeah, no. The SSBs are a great single message target and can mean 10 pounds in 2 months if someone is drinking a liter a day, which some people are.
Use the technique of intermittent fasting at all?
I do not recommend that, but if someone is, people come and ask me various things, and as long as it's not unhealthy or too extreme, I don't necessarily discourage them.
Yom Kippur starts tonight, Sunday. Well, thank you, everybody. We'll wrap it up now. Thank you, Dr.
Thank you.